Bene, nuovamente buonasera a tutti e grazie di aver aspettato anche questa riunione importante. Io introdurrei adesso il professor Roccatello, ma permettetemi di indirizzare al professor Robin qualche parola di circostanza. Ma first of all, let me thank you very much, dear friend Dario ROCCATELLO, the member of this academy, for his dedication in organizing this evening, this night, and also the meeting that took place today. Moreover, I would like to welcome Professor Robin, professor at the Wexner Medical Center of the University of Ohio, for accepting our invitation. His reading will certainly be followed with great interest, considering his expertise on the subjects of lupus. The Academy of Medicine is honored to conclude its social year with a prominent presence in the international scientific panorama that will certainly bring to all us a high-level cultural contribution. Thank you again. Prego, Dario.
Abbiamo organizzato, come potete apprezzare, una sottotitolazione per rendere più facile anche a chi è lontano, sente magari, insomma, non riesce a cogliere alcuni aspetti, per agevolare la comprensione della conferenza di Brad ROVIN. Brad ROVIN è la figura più di spicco nell'ambito del trattamento della malattia lupica renale, più di spicco nel mondo. Sembra una cosa buttata là, invece è proprio così. E adesso cercherò di, attraverso una brevissima sequenza di slide, cercherò di mostrarvi quanto Brad ROVIN abbia contribuito nella nostra pratica clinica. Quelle che vedete sono, quello che vedete è lo schema, l'algoritmo di trattamento della nefrite lupica proliferativa. E ci sono due principali nefriti lupiche che vengono trattate, che sono la forma proliferativa, sono due sottoclassi, e la forma cosiddetta membranosa. Quella membranosa è un po' meno ricca di esperienza perché i numeri sono piccoli e non si sono potuti produrre grandi trial controllati, mentre sulla nefrite proliferativa c'è stato uno scatenarsi in questi anni di diversi trial randomizzati e controllati che hanno costruito le linee guida di trattamento che sono descritte in questo algoritmo. Si chiamano KDIGO. E di queste KDIGO Brad ROVIN è il corresponsabile insieme al professor Flöge, che organizza non soltanto sulla nefrite lupica, ma su tutto il panorama del nefrologico, tutto il panorama disciplinare, organizza delle linee guida che si fondano sugli schemi, su trial randomizzati controllati. Questa è la filosofia con cui sono state costruite queste linee guida internazionali. Nella nefrite proliferativa ci sono fondamentalmente due regimi, uno che associa lo steroide col micofenolato, l'altro con la ciclofosfamide. E poi, tutto recentemente, sono stati proposti due altri schemi che sono agli estremi della parte bassa della slide, e sono una combinazione di piccole dosi di micofenolato con inibitori della calcineurina e nelle mani dei giapponesi anche con piccole dosi di ciclofosfamide. Dall'altra parte, alla vostra destra, invece la combinazione di un biologico che si chiama belimumab con il micofenolato. In questo caso si tratta di una terapia che si chiama add on top, cioè è stata aggiunta a quello che viene chiamato lo standard of care, cioè il trattamento standard degli anni precedenti. Su questi trial, a questi trial Brad ROVIN ha partecipato in maniera importantissima e ne ha anche stigmatizzato i limiti. Per esempio sul belimumab, che in questo momento è una delle medicine più usate in reumatologia, ma anche in nefrologia, ha sottolineato come dagli studi randomizzati emergesse che non era per tutti i pazienti, ad esempio quelli con maggiore proteinuria non andava bene con la combinazione con micofenolato, ma non con la ciclofosfamide. E la voclosporina è stata l'altra grande novità degli ultimi anni, di nuovo si è basata su uno studio, la sua introduzione è basata su un trial controllato, randomizzato, disegnato, pilotato dal nostro ospite e da questa esperienza è emerso come si potesse trattare il lupus anche con delle dosi incredibilmente basse, quasi la metà di quelle che normalmente noi usiamo in clinica. E poi si è potuto guardare a questo farmaco come una terapia per tutti, perché normalmente si crede che il micofenolato vada meglio nell'ispanoamericano e nel nero, la ciclofosfamide nel caucasico, queste combinazioni di piccole dosi di immunosoppressione nell'asiatico. La voclosporina si è visto che non fa differenza attraverso le etnie e poi può essere applicata con vantaggio anche nelle forme più severamente proteinuriche. Ancora, Brad ROVIN è stato coinvolto molto in un altro farmaco che si usa tantissimo nella pratica clinica, ma che Brad ROVIN nel suo disegno, questo devo dirlo, un po' infelice, ma allora non si poteva sapere perché è stato uno dei primi disegni sperimentali, poi che peraltro ha segnato, è stata un'esperienza sulla quale si sono fondati tutti gli altri trial, nel senso di prolungare la durata del trattamento, insomma altri escamotage anche di carattere, diciamo così, di valutazione statistica, che hanno migliorato le performance dei nuovi farmaci. Comunque il rituximab è un anticorpo monoclonale anti-CD20 che nella pratica clinica si usa tantissimo, ma che in un primo trial, di cui di nuovo Brad ROVIN è stato l'artefice, non ha mostrato, aggiunto alla terapia, allo standard of care con micofenolato, di dare dei grandissimi vantaggi rispetto al placebo, ma in uno studio successivo, di nuovo firmato da Brad ROVIN, una cosiddetta post-hoc analisi, si vide come quei pazienti che rispondevano con una profonda deplezione dei linfociti B potevano in effetti potevano avere quella remissione renale completa che si sperava di poter ottenere con questo farmaco. Allora qui ne approfitto per una brevissima parentesi che riguarda la nostra esperienza con questo farmaco, con il rituximab organizzato in una dose che abbiamo così messo insieme, non dico inventato, ma insomma insieme con i suggerimenti di Corrado Tarella, che qualcuno di voi ricorda, un ematologo che adesso lavora all'Ohio, ma che è stato per tanti anni qui a Torino, ed è una combinazione di rituximab e ciclofosfamide che azzera il CD19. Con questa combinazione abbiamo ottenuto dei risultati non molto, ma migliori dello standard of care con micofenolato o con ciclofosfamide, con un aspetto che io reputo di grande interesse, ma che essendo noi un po' troppo vicini all'Africa, la Tunisia non è stato molto colto, e che con questo schema e senza fare una terapia di mantenimento ulteriore si riusciva ad ottenere che il 70% dei pazienti trattati poteva rimanere in remissione stabile per 40 mesi senza malattia e senza farmaci. Tanta roba. C'è un farmaco più moderno oggi del rituximab che si chiama obinutuzumab, che è un monoclonale ingegnerizzato per ottenere una deplezione dei linfociti B ancora maggiore e più efficace. E questo farmaco, di nuovo, il trial registrativo del farmaco, ha di nuovo la firma di Brad ROVIN. E quello che ha questo farmaco straordinario è che la maggior parte dei pazienti riesce a ripopolare il circolo periferico con nuovi linfociti B dopo la deplezione, addirittura con una media di 80 settimane, quindi una deplezione formidabile. E su questo farmaco ci sono delle grosse speranze anche per il trattamento delle forme refrattarie. Ci parlerà Brad ROVIN di un'altra frontiera, che questa volta non è partita direttamente da lui, è partita dalla scuola tedesca, che sono le carticelle applicate al lupus. Le carticelle sono in pratica sono delle cellule che vengono prelevate nel lavoro originale dal paziente, ingegnerizzate, restituite, previa una terapia di condizionamento, e l'idea è che possano essere usate con grande efficacia nel lupus refrattario. Ed effettivamente negli studi della scuola tedesca i risultati sono eccellenti, si parla addirittura di un resetting immunologico che consentirebbe al paziente di stoppare la terapia. In fondo quello che avevamo ottenuto con il nostro protocollo intensificato, ma questa volta con tutta l'industria e tutti i ricercatori molto coinvolti su questo tema. Non so se lo dirà Brad ROVIN, lo dico io perché è una roba che lo anticipo. Nella terapia di condizionamento questi pazienti fanno un sacco di fludarabine e di ciclofosfamide. Nella nostra esperienza quelle dosi di immunosoppressore in genere sono sufficienti ad ottenere dei buoni risultati di remissione della nefrite lupica senza fare tanto spostamento di cellule. Però questa è una considerazione generale. Noi tra l'altro abbiamo aperto a nostra volta un fronte di utilizzazione di questi farmaci, di questa procedura, di questa strategia terapeutica anche nel nostro centro. Quindi l'altro aspetto che è un pochino più inquietante è che sono stati descritti dei casi di linfoma cerebrale, perché queste cellule che vengono prese e poi manipolate in qualche modo non se ne fanno sempre una ragione. Comunque, l'ultimo aspetto sul quale ancora non è stato direttamente coinvolto Brad ROVIN, ma lo sarà a brevissimo perché sta montando uno studio ad hoc con un altro farmaco rispetto a quello che vi farò vedere, e la strategia la strategia antiplasma cellulare, cioè anziché diretta verso il linfocita B che è diretta verso la plasmacellula direttamente, che si pensa le plasmacellule possano relegarsi in nicchie che le monoclonali anticidiventi non riescono a raggiungere. Allora ci sono state delle esperienze in passato, di nuovo della scuola tedesca con Bortezzomi, che è stato preso dall'esperienza ematologica, ma il farmaco ad oggi più moderno è quello che ci ha consentito di arrivare ad una grossa rivista internazionale con un'esperienza su un piccolo numero di casi refrattari. Si chiama daratumumab ed è diretto verso il CD38 che è rappresentato sulla superficie delle plasmacellule e anche altre cellule. Mi piace ricordare, perché è una cosa di cui sono molto orgoglioso, che l'anti-CD38 daratumumab è un farmaco nostro, di questa università. L'ha prodotto Fabio Malavasi, che tra l'altro è anche un socio, credo, dell'Accademia. E Fabio Malavasi ha poi passato il brevetto all'industria e ne è uscito questo farmaco che ha ottenuto dei risultati molto buoni nelle nostre mani, proprio in casi altamente refrattari. Io credo che qualche cenno farà anche Brad ROVIN, non tanto sul daratumumab, ma su un altro anti-CD38 che stanno introducendo in America. E la cosa che mi piace mostrarvi, che deriva da una valutazione che ha fatto il professor Sciascia del nostro gruppo, è che il panel citochimico che si ottiene con una terapia di daratumumab nel lupus è del tutto comparabile a quella che si ottiene, lo vedete a sinistra, con le carticelle. Brad ROVIN è direttore della divisione di nefrologia dell'Ohio State University ed è anche vice direttore del centro di ricerca locale, è specialista in nefrologia, ha un particolare focus sulle glomerulonefriti, la nefrite lupica in particolare e le vasculiti. Però ha una conoscenza straordinaria a 360 gradi su tutta la nefrologia, come abbiamo potuto apprezzare nelle cene che hanno fatto seguito alla sua partecipazione come visiting professor al corso internazionale di San Luigi per gli studenti di medicina. Ha diversi ruoli di leadership nella American Society of Nephrology e co-editor del NEFSAP, Glomerular Disease, che è un'iniziativa educazionale di altissimo profilo legato all'American Society of Nephrology, e l'editor, il deputy editor di Kidney International, che è la Bibbia dei nefrologi, ed è il co-chair, come dicevo prima, delle KDIGO, che sono le linee guida, cioè sono in pratica la via da seguire per tutti i nefrologi per non incappare in alcun incidente di percorso. È un onore straordinario, un'occasione straordinaria di apprezzare questo personaggio veramente fuori dal comune, che come avete potuto apprezzare è dentro qualunque step degli ultimi 10 anni di trattamento della nefrite lupica. Grazie professor Rovin per essere qui.
Grazie, Dario. Grazie mille. It's a real pleasure to be here, and I'm happy to talk about new frontiers in the treatment of lupus. And sort of the subtitle of this is, Can we cure lupus nephritis? And by the end of this, you'll see my opinion on that, I think. These are my potential conflicts. I work with a lot of companies to help develop new therapies. I hope that this will not affect this presentation. Okay, so as I think Dario was telling you, that the latest trend in lupus nephritis therapy right now is to achieve deep B-cell depletion and reset potentially the immune system of lupus patients, and then maintain the patients off of medications for at least a prolonged period of time, if not indefinitely. Despite the attribution of this idea to the Schett group in Germany, and I will show these data just in a minute, this originated right here in Torino. This was Dario's, at least my first encounter of his deep B-cell depletion therapy. And I know he went over this a little bit in the preamble, but he took patients who were refractory or intolerant of the usual therapies for lupus nephritis and treated them with what we had at the time to deplete B cells, which was rituximab. And as you'll see, rituximab happens to be the least effective, potentially, of the B cell depleting drugs. And then on the background of cyclophosphamide and some steroids, he really worked hard to deplete the B cells with multiple doses of rituximab. And even though my last bit of the slide is covered up by the translation, it's not even a translation, is it? The last bit of the slide is covered. What he was able to show was that the majority of the refractory patients or intolerant patients actually went into a complete renal response. And for many months or years, I don't know how long it's been now, he's been able to keep them off medication. So this was really, in my opinion, the start of this idea of deep B-cell depletion. So let me just go over, I know everyone in the audience is a different sort of physician or medical professional. And so cell therapies is really the hottest topic in the lupus world right now. And cell therapies, I've had this little illustration, are being done as follows, and then they're being modified. But basically, for those of you who work in oncology, this is very similar to getting patients ready for an auto transplant. The patients are phoresed, and then the cells are taken out, and in a laboratory somewhere, they're transfected with an adenovirus. And with the adenovirus, you can actually take the T cells and target them to whatever you want. And there's a lot of combinations that are being thought of right now. But for our purposes for today, the CAR T cells that have been generated to look at lupus nephritis are CD19 CAR T cells. So the CAR T cell is directed against a B cell antigen to kill the B cell antigen. Or I will show you an example of a bispecific CAR T cell, which is CD19 and BCMA, to hit the B cells as well as plasma cells and plasmablasts. Anyway, that process takes about 2 weeks, and over that ensuing period of time, the patient is then conditioned with a very rigorous lymphodepletion therapy. And right now, we use cyclophosphamide plus fludarabine to eliminate lymphocytes from the patients. This conditioning regimen should give us pause because these agents, we're pretty used to cyclophosphamide as nephrologists and rheumatologists. Fludarabine is something out of the domain of the oncology and hematology world, and it does worry me a little bit given the age of our patients and their prospective long lifespan, because some of these drugs are associated with future malignancies, as you well know. Eventually, the patient's CAR T cells are ready. This is an autologous infusion, and this is done in hospital, and then the patients are observed in hospital for a couple of weeks. And then, in point of fact, they have to stay by the medical center for the next several months. So you can understand that this is really a very committed patient through a very complicated procedure. So this was the report that started the frenzy. And I use the word frenzy because there are now some 30 or 40 companies that have put their hat in the ring to do some sort of cell therapy for lupus and lupus nephritis. And all of these are targeting refractory patients. I don't have that many refractory patients in my practice, and I would challenge you to find truly refractory patients. Most of what we consider refractory disease, if you really talk to the patient, is because they're not adherent to their regimen. So this really presents a problem with so many folks in the space right now in terms of getting these trials filled. But that was a little bit of a digression. This shows you some of the characteristics of the patients that were in the Schett trial. And what you can see uniformly is that these were very young patients. They had a variable duration of lupus and lupus nephritis. You can see here the proteinuria, and I would hesitate to say that a patient with 80 milligrams of protein in the urine is a truly refractory lupus nephritis patient. I will tell you that there's some consideration that these might not have been as refractory as what we're seeing being enrolled in trials in the United States right now, and we'll get to that in just a minute. They had various classes of lupus nephritis, and this is unfortunately a little covered up. They were treated with several different types of therapy, but they really didn't have very much in the way of B-cell depleting therapies. I think only 1 or 2 patients were treated with rituximab. Some of the patients were treated with belimumab. Okay, so those patients were then followed over time, and this came out is the 2-year follow-up just this past year in the New England Journal of Medicine. And everything you need to know is said in the title of this. The 2-year results after CAR T cell therapy in these now 8 patients, they added 3 more, was 100% complete renal remission within 3 months, which is remarkable in and of itself, and no lupus nephritis relapses off all immunosuppression, and the follow-up is over 29 months right now. So this is absolutely remarkable. First of all, and I don't know how many nephrologists are in the audience, it's very unusual to me to be able to see a resolution of proteinuria in 3 months in a refractory patient who's had lots and lots of therapy, because by and large those kidneys are damaged and you almost never can have resolution of the proteinuria. It's also remarkable the rapidity with which that response occurs. We don't see that very often unless there's a hemodynamic effect. we are really trying to understand what's going on in these therapies. And I will tell you that this is the best you're going to see going forward, because none of the other companies that have jumped into this space are getting these kind of results. So this is sort of perfection. What you see in these patients is that very quickly, one of the indices used by rheumatology to classify severity of lupus goes to about 0 very quickly. Double-stranded DNA antibodies go away in all the patients. Complement levels improve. This is C3. And you can see here, proteinuria comes down. You can't see the details of it, but all of these patients remarkably had resolution of their proteinuria. One patient actually had a relapse of proteinuria a few months into the treatment regimen, and it turned out that when that patient was rebiopsied, we were told that he had lupus podocytopathy, which is not a recurrence of his lupus nephritis or her lupus nephritis. So one of the things that should be clear is that CD19 CAR T cells, which are targeting basically B cells, do not eliminate all of the autoantibodies. And you see here several autoantibodies that are present in lupus that are not taken care of, like the double-stranded DNA. This is likely because CD19 does not target mature, long-lived plasma cells. And for that, you would need another T cell engager. And I'll show you those data in a minute. So the sensitivity of autoantibodies to B cell depletion really depends on what is making the autoantibody. And you can look at short-lived plasma cells and long-lived plasma cells. Short-lived plasma cells include antibodies, making antibodies that are found in pemphigus, and then covered up here is PLA2R, autoantibodies, which we see in membranous nephropathy. And we know that in membranous nephropathy, not lupus membranous, idiopathic, we used to call idiopathic membranous, we know that B cell therapies work pretty well in those particular patients, because once you get rid of the B cells, the plasma cells are short-lived, they don't reconstitute. And then you have long-lived plasma cells down at this end of the spectrum. These are mostly what we see after vaccination for infectious diseases. And then when we think about lupus, double-stranded DNA autoantibodies are probably made by short-lived or moderately long-lived plasma cells, and other antibodies are made by long-lived plasma cells. If you look at this particular CAR T cell, this was a construct in which the T cells were modified with CD19 and BCMA to target both B cells and plasmablasts and plasma cells. You see a very similar sort of data pattern as with the George Schett experiment. These CAR T cells were also caused minimization of the proteinuria very quickly, depletion of B cells, et cetera. But what these CAR T cells were able to do, because they're attacking the plasma cell as well, is that they were able to deplete all of these measured autoantibodies in patients with lupus nephritis. And I'm going to ask the audiovisual, is there a way to get rid of this? Is this translation helping anyone since it's not translating? Okay, good. I don't know how to get his attention, but maybe we could make it go away because you're missing like a third of what I'm trying to show you. Oh, you did it. Oh, make it go away.
Yes.
Grazie.
See?
Okay, thank you. All right, now that's better. Okay, so these are the results looking at the CD19 BCMA CAR T cell. And what you see here is a little bit less profound effects than we see in the shed experiment. The GFRs were a little bit all over the place, and you can see that the protein to creatinine ratios in general improved, but most patients didn't go to zero. And I think this is a much more realistic expectation of what we might see. This particular patient had a kidney biopsy after the CAR T cell. I think it was a number of months after the CAR T cell. And what I want to point out in this kidney biopsy is this is immunofluorescence for IgG, IgM, IgA, C3, and C1q. And what's absolutely remarkable to me is the complete absence of immunofluorescence for these antibodies and complement components after the CAR T cell therapy. And why do I say that? We, with my colleagues and I, have done serial biopsies in patients with lupus nephritis who have done remarkably well with conventional therapy. When you do serial biopsies of patients with lupus, the very last things to go away are the deposition, the deposited immunoglobulins. IgG can remain in the kidney for years after successful treatment of lupus nephritis using conventional therapies. This seems to wipe everything out very nicely. So I do believe that the CAR T cells are doing something very interesting in the kidney. It's hard for me to explain how they do it so quickly. Okay. One of the things that you might ask is, well, this is a pretty intensive therapy. And I think, as Dario was pointing out in the introductory statements, there are certain things, the adverse events that are associated with CAR T cells. One is called cytokine release syndrome, and cytokine release syndrome comes primarily from activation of the transfused T cells that get into the body. And the T cells release all sorts of cytokines. We measure IL-6. IL-6 can go up several log-fold in patients with cytokine release syndrome. And the patients can have symptoms varying from mild fever all the way to what he pointed out was the worst complication, which is a neurologic manifestation of cytokine release syndrome. We call it ICANS. And it turned out that in the Schett experience, nobody had any neurologic symptoms. Everybody did really well. It was sort of like the best thing that could happen. And now that we're doing these trials in other places in the world, including the United States, we are seeing some of the side effects that we see when CAR T cells are used for lymphomas and leukemias. In specific, one of the CD19 patients in this particular trial, lupus nephritis, very active refractory disease, developed neurologic symptoms that required her to be in the ICU for several days. She survived, and she actually had cleared up, but this was the highest toxicity level that's possible. We also have seen that several patients are developing much more than very mild cytokine release syndrome. Okay, so the idea that this can be given absolutely without side effect, I think, is a wrong idea. Okay, the other thing that's sort of interesting is that in the United States, not all of the patients have gone into remission like the German patients. And beyond that, patients have relapsed with their lupus nephritis very quickly after CAR T cell infusion. And so that, to me, is not surprising, because it would be hard to believe that every single person was going to respond and no one was going to have any side effects. But it does give us some pause as to how we might think about applying this to all of our lupus patients. The other thing that I think is important to know is that in 2023, towards the end of the year, so about a year ago, the Food and Drug Administration in the US released a statement regarding the discovery of T-cell malignancies in patients who had received CAR T-cell therapy. And at least in some of the patients, the feeling was that these T-cell malignancies were from the infused CAR T cells. I realize now that that is still a little bit up in the air, and it's not clear what this really means for our patients. The oncologists that I work with sort of say, well, this happens so rarely, it's really not a complication we're worried about. And they justify it, rightfully so, when you're using the CAR T cell in the patient who has a malignancy. By and large, these are older patients. They have a much shorter total lifespan, and they have a disease that's pretty much going to kill them in a short period of time. This is the complete opposite of what we have in our lupus patients, who have a very long time horizon and generally have a disease that's not going to kill them. Now, it may kill the kidneys and they may need dialysis and transplantation, but the oncologists have come up with sort of a little algorithm to talk to patients about. And all of this is really true for a patient with cancer. I don't believe that many of these arguments hold very well in patients with lupus or other autoimmune disease for which the CAR T cells are being used. So again, I'm suggesting a little bit of caution in our exuberance over CAR T cells. Okay, now one of the things I'd like to do is talk about obinutuzumab. Obinutuzumab is an anti-CD20 therapy, and I want to compare and contrast it to the CAR T cell experience. And why am I doing this? Well, two reasons. One is we've been studying obinutuzumab in the treatment of patients with lupus nephritis. It's like rituximab, except it's much more potent, and it's by looking at its use in people with lymphomas, seems to have better tissue penetration than rituximab. So the question is, we can easily deplete, and deplete very well, circulating B cells. Is that sufficient, or do we have to start depleting B cells and or plasma cells in the tissue? And then the tissue means bone marrow and lymph nodes and spleen. Okay, so that's sort of the background of why I want to compare and contrast these two. The other thing is that the phase 3 trial of obinutuzumab in patients with lupus nephritis just read out, and the results are positive. So we're optimistic that this may get approval by the FDA and in Europe, the EMA, for use in lupus. And of course, it's a monoclonal antibody, not without side effects, but something that would be a much easier regimen to endure than having what's essentially a mini bone marrow transplant. Okay, so I can't show you the phase 3 data yet because they're embargoed, but I'll show you here the data that we have from the phase 2 trial. And what you see right away is that obinutuzumab in the bottom line here at 12 months and at 24 months actually performed better in terms of patients achieving a complete renal response compared to the placebo group. But what is absolutely clear is that we did not get 100% remission in the patients that were treated with obinutuzumab. And in fact, we didn't even get 50% remission in those patients. So here's something that's really important. If we believe that everybody or most everybody with a CAR T cell therapy is going to go into remission, this is quite different. The other thing that I'll point out is that this is a post hoc analysis that we did after the phase 2 obinutuzumab trial, which was over 2 years. And what you see here is a benefit in renal flares in the obinutuzumab group. There were fewer lupus nephritis flares, significantly fewer than in the placebo group. However, there were not zero flares. Okay, and let me emphasize this a little bit more. The patients in the obinutuzumab study were maintained on immunosuppressive therapy. So I'm comparing and contrasting with CAR T cell. The CAR T cell so far, very rapid remissions, everybody remits, no flares, no maintenance medications. Obinutuzumab, flares, on maintenance medications, and not everybody, not even the majority of patients remit. Okay, so there's a disconnect here, I think. And let's try to figure that out. I think this is absolutely remarkable when you think about it. This is the CD19 B cells in patients, the first 5 patients that the German group treated. And you can see that within probably 3 days, there were no more circulating B cells, period, end of story, right? But what you can see here in the solid lines is that B cells started coming back within 2 months of the patients receiving CAR T cells. So there was very profound depletion of circulating B cells with CAR T cell therapy, and the B cells returned very, very quickly. In contrast, this is the Nobility study. This is the phase 2 study of obinutuzumab. You see that within 2 weeks, we had 98% of the patients with B cell depletion. So we got very nice B cell depletion with obinutuzumab, and it lasted for a really long time. So CAR T cell mediated B cell depletion is profound, rapid, and very short-lived. Obinutuzumab mediated B cell depletion is profound, rapid, and very long-lived. And yet, we don't see obinutuzumab having the same sort of efficacy as the CAR T cell. So one of the considerations is this idea of, can we reset the immune system by giving the CAR T cells and having a profound depletion of B cells? And when you start to see what B cells come back, you'll notice here, and this is about 3 to 4 months, the B cells that are coming back after CAR T cell therapy are naive B cells instead of memory B cells. None of the memory B cells are really coming back, which suggests that maybe as the B cells reconstitute after CAR T cell therapy, they have lost the memory needed to get lupus or whatever autoimmune disease you're using up and flaring again. A very interesting idea. Okay. However, and this is actually the same sort of analysis with the people who are getting the CD19 BCMA CAR T cell experience. This is a lot of stuff to look at, but basically, naive B cells come back. Most of the other memory B cells don't come back. Okay, so are we resetting the immune system, and what's obinutuzumab doing? So it turns out that in the phase 2 trial, we actually looked at B cell subsets as the B cells recovered after obinutuzumab therapy. And what you see here, this is BAFF. So we know when we kill B cells, B cell activating factors increase. That's fine. But what you see here is that these cells are the naive B cells, and it's generally, here you see the naive B cells. This is the obinutuzumab. We deplete the B cells quickly, and the cells that are coming back are naive B cells. The memory B cells are depleted in obinutuzumab in the blue line, and the memory B cells are not coming back. and these are plasmablasts, and the plasmablasts are not coming back. So the very simple interpretation of this is that when the B cells reconstitute after anti-CD20 therapy, they are looking very similar to the reconstituted B cells after CAR T cell therapy. And so again, I pose the question, what's happening with CAR T cells that's so profoundly different to get this kind of results that we've seen? And I think that the answer lies in, there we go, in the tissue. The tissue is maybe the issue for the CAR T cells. And so there are not many of these experiments done with humans, but I'll show you what we have, and I think you'll find it very interesting. So these are lymph node biopsies after CAR T cell treatment for autoimmune disease, not for malignancies. These are not necessarily patients that all had lupus nephritis, but they had various refractory autoimmune diseases. The inguinal lymph nodes were biopsied, and this was done about 60 days after the CD19 CAR T cell was infused. We also can compare it to rituximab. Okay, this is post-rituximab. This is about 100 days after rituximab therapy. And what you can see here, these are pre-CAR T cells. You see the lymph node looks really nice, and you see the lymphoid follicles, et cetera. You can stain for CD19 positive B cells, and you see plenty of them, and CD20 positive B cells, and then plasma cells. So this is pre-CAR, oops. That's pre-CAR T cell therapy. Okay. After the CAR T cell therapy, you see nothing that looks like a lymph node anymore. The lymph node is complete, the structure of the lymph node is blown away. You see no CD19 B cells, you see no CD20 B cells, and you do see a few plasma cells remaining. In contrast, look at what happens after rituximab therapy. So this is post-rituximab therapy. We maintain the germinal center and the lymphoid follicles of the lymph node. We still have plenty of CD19 and CD20 B cells in the lymph node, and we have plasma cells. So the bottom line is, at least for rituximab, we're not getting rid of tissue-related B cells very well. I realize this is not obinutuzumab. I'll show you some obinutuzumab data in just a minute. This is the lymph node architecture after the CAR T cell therapy, and you see that we lose follicular dendritic cells, T follicular helper cells. You still have proliferating cells in the lymphoid tissue. You see that these are not lost in patients that are post-rituximab therapy. Why are T cells disappearing in the lymph nodes along with the B cells? Because the CAR T cells aren't killing T cells. Well, it's possible and probable that T follicular helper cells and follicular dendritic cells actually need B cell help to survive. And when you lose the B cells, you lose those structures and those cells as well. Okay. What does the kidney look like after CAR T cell therapy? I think that's a relevant question because we know that in patients with lupus nephritis, B cells and plasma cells are within the kidney parenchyma, and they may be contributing to the tissue autoimmunity that we see in lupus nephritis. And unfortunately, there was not a pre-CAR T cell biopsy in this particular case that was stained for CD20. But what you see here is the kidney after CAR T cell therapy. You see there's no CD20, there's no CD19. So we can assume that there was to start with, and I think that's a fair assumption, although can't prove it. but we still have macrophages in the kidney and we still have T cells in the kidney. So we see a remarkable depletion of tissue niches of CAR T cells. Now, I think a relevant question to me, and I can't answer it, would be what does the bone marrow look like after CAR T cell therapy? And I have not seen any data to that effect. Nobody has been doing bone marrow biopsies after the CAR T cells in autoimmune patients. I'm sure they're done in cancer patients. So do we have anything similar to look at the tissue effects in non-malignancy in patients treated with obinutuzumab? And I'll just show you this one trial. This was called the Theory trial. It was a phase 1 trial to look at obinutuzumab treatment of highly sensitized kidney transplant patients with end-stage kidney disease. So these patients were forming antibodies and they couldn't get a kidney transplant. So the idea was treat them with obinutuzumab and see if you can then eliminate the antibodies and allow the patient to be transplanted. And while they were doing this, after obinutuzumab was given, when the patients were receiving their kidney transplant, the inguinal lymph nodes were biopsied. And what you see here is the control tissue and then the obinutuzumab treated tissue. And obviously in control tissue, there's plenty of B cells in the lymph nodes. And after obinutuzumab, you can say, well, that's a pretty good depletion, certainly compared to what we saw with rituximab. I understand they were not side-by-side comparisons, so take what I'm saying with a grain of salt. But I think what you can also see is there are plenty of B cells left in the tissue. And so this really raises the question that perhaps the reason the CAR T cell therapies are so effective is because they really lymphodeplete throughout the lymphoid system. I'm going to call the kidney part of it, the kidney, lymph nodes, and maybe even the bone marrow. So I want to be like my kids and say the CAR T cell therapy with autologous CAR T cells was so yesterday, and it was really came on the scene just a very short while ago. We are now looking at off-the-shelf allogeneic CAR T cells. One of the problems that in CAR T cell therapy for malignancies as well as here is that when you transfect person A with an adenovirus, you expect when you transfect person B with the adenovirus that their CAR T cells are going to look the same, behave the same, and be as effective. There's no way of checking that, and they actually seem to be heterogeneous. So it's entirely possible that autologous therapies may or may not work, depending on how well the transfection actually took. And the other problem with that is that there's no standard for measuring these sorts of things. So there's at least 3 companies now that are developing CAR T cells. So they take a T cell source, they actually genetically modify the T cells to get rid of all the antigens that would cause rejection, because these are from not an autologous donor, they're allogeneic, and then they make the CAR T cell product. So that's really very interesting. These hypoimmune CAR T cells could be standardized, and instead of waiting 2 weeks for production of the CAR T cell, you pull the CAR T cell off the shelf and transfuse it into the patient. Cell therapies with other cell types are being considered. We're now using CD19 NK cells in conjunction with anti-CD20 antibodies. These are allogeneic CD19 NK cells. And the idea is, can we take a CD20 antibody like rituximab and profoundly enhance the killing of B cells a la tissue? We don't know the answer to that yet. We're doing this trial at my university. It has yet to be activated. Most of the pharma are at least considering reduction or elimination of conditioning with cyclophosphamide and fludarabine. Now, when you're thinking about a patient who has leukemia or lymphoma and they're being treated with CAR T cells, you clearly want the CAR T cell to kill every B cell that it possibly can because you don't want the malignant cell to come back. It's not clear to me that you have to kill every single B cell for lupus or lupus nephritis. So we've been pushing the companies to actually create an arm in their trials that doesn't have this rigorous conditioning regimen, which is very concerning for patients who are young and have a long lifespan. And then bispecific engineered antibodies are the latest thing. And these are being developed by many companies, and I'll show you that in just a minute. But these bispecific antibodies are designed to bring T cells into contact with B cells. So there'll be an antibody that has a CD19 wing and a CD3 wing, and they bring the T cells and B cells together. And this way, the T cells within the patient's own body kills the B cells. And so this is an example that was just published in the New England Journal of Medicine. I can't pronounce this, but it is a bispecific antibody that is against CD3, of course, a T cell surface antigen, and BCMA, a B cell and plasma cell antigen. The T cells are then activated when they come in contact with the B cells to kill the B cell and to kill the plasma cell that they bind to. So it turns out that these are very effective. This is a patient, this is a single example, I understand that. It was given to a patient with class 5 lupus nephritis, multiple other systemic manifestations of lupus that were not controlled by hydroxychloroquine, methotrexate, azathioprine, mycophenolate, voclosporin, belimumab, or anifrolumab. So they went through every anti-lupus therapy that was possible to go through, and they did not have success. And so the patient received 5 doses of this bispecific antibody. Other immunosuppression was stopped. And you see here a remarkable decline in the protein to creatinine ratio. It does not go to 0, which I don't expect it to. You see the interferon signature. This is a measure of the interferon signature drop within 6 weeks of giving the antibody. Interferon alpha is thought to be a cytokine that may be important in pushing lupus and lupus nephritis. It's elevated in most of our patients. You can see that there's a decline in stabilization of the serum creatinine. Double-stranded DNA antibodies go away. Complements actually get better. And you can see that the B cells are depleted very, very quickly, just like the CAR T cell. Now, because these are T cells that are being activated to kill B cells, the unfortunate situation is that you can have cytokine release syndrome, just like you can with CAR T cells. And what I'm showing you here is that there was a huge increase in this patient's IL-6 level, and they developed symptomatic cytokine release syndrome. They did not develop neurologic manifestations, and they were treated with tocilizumab, and then this resolved. Now, if you look all the way to the right, it's looking at the bone marrow. This patient had a bone marrow biopsy to look at B cells and plasma cell depletion before and after the infusion of the monoclonal antibody. And you see before and after, and you see that plasma cells decline tremendously in the bone marrow and B cells decline tremendously in the bone marrow. What's really interesting is the plasma cells look like they almost all go away. There's still a fair number of B cells in the bone marrow. It hasn't completely been depleted. I can't compare it because I don't know what happens to the B cells in the bone marrow of the CAR T cell patients. So this really looks a lot like CAR T cells without the conditioning or the manufacturing of cells. Okay, so let's finish up. This is a graph I borrowed from one of the companies that is doing CAR T cell therapy, and this sort of compares all of these therapies that target B cells and looks at the depth of depletion. Monoclonal antibodies, so rituximab and obinutuzumab, have modest B cell depletion and depth of B cell depletion. And then when you're done with dosing of that, you have to continue background immunosuppressive therapy. At least we think so far. The bispecific antibodies have much greater depth of B cell depletion. Generally speaking, you have to give a couple of cycles of the bispecific antibodies, and you may actually have to continue immunomodulation. Now, what's really interesting, however, is that I'm working with a company that is developed a bispecific, and we're actually doing a trial where we will remove maintenance immunosuppressive therapy. So we're trying to emulate a CAR T cell type of response. And, you know, obviously this slide was made by a CAR T cell company. I don't know if the depth of the bispecific antibodies is less than the depth of the CAR T cell or not, but they want it to look like that. The difference in the CAR T cell therapy is it's sustained over many months, and it's a single infusion, and then you're done without maintenance therapy. So there's advantages to that, and you can tell the advantages right off the bat. Young people don't want to be on medications. They would like to have a normal lifestyle. So the question really is, and I'll leave this to you in my final slide, how deep is deep enough? And my suspicion is we need to look at the individual patient. We know from work that other people have done, work that Dario has done, that if we have excellent peripheral B cell depletion, it works really well for some patients. Other patients might not respond or may flare later, and some might not respond at all. And we don't know how to correctly identify who's going to respond to what depth of B cell depletion. And I think we have to figure this out. Tissue B cell depletion seems very complete with the CAR T cells and variably complete with anti-CD20. And just what is enough tissue depletion remains to be seen. While the initial data from that small number of perfect patients that I showed you in Germany is very compelling, I hope you realize that nothing in medicine, of course, is perfect. And as we do more and more CAR T cell therapies in our patients, we're starting to see the side effects that are expected, and not everybody is going into remission. And I think that's not to be unexpected. I don't think any therapy is going to work for everyone. So I think the reality is we're going to have to figure out who among our patients need the CAR T cell therapy. My guess is that we're going to treat some patients very nicely with regular rituximab or obinutuzumab, as we've been doing. Other patients, we may need to get a little bit deeper into the tissue, and that might be the bispecific cells. It may also be, I think, as Dario was talking about in the beginning, the combination of a B cell therapy with a plasma cell therapy, and that's being trialed right now. Daratumumab he used in his studies, and there's a new study of something called felzartamab, which is also a CD38 antibody. And then there's going to be a handful of patients that probably need the ultimate in B cell killing, and that would be those who need the CAR T cells. Happy to answer any questions. Thank you very much.
Thank you very much. Qualche domanda? Prego, professor Medico.
Thank you very much. Excellent presentation. And I'm in the oncology field. I didn't know about the application. So my question is, would CAR T cells work all alone when they deplete, or do they somehow announce some kind of local activity of other cells that could help them in the killing and generate a more immunoactive environment?
Yeah, I think that the NK CAR T cells are designed to work in that way, where they're combining different things to cause killing. The CAR T cells, the CD19 CAR T cells, I think are designed to kill by themselves.
And they do all by themselves.
Yes. And I, you know, one of the things that we're still not entirely certain about is before you get the CAR T cell, you get massive lymphodepletion with fludarabine and with cyclophosphamide. Are we doing something to the patient to help things along by doing that? In other words, nobody's going to do the trial of CAR T cell placebo plus cyclophosphamide and fludarabine. It's just not going to be done. But you can see where I'm a little bit skeptical, and so is Dario, because you're killing all the lymphocytes with the fludarabine. Well, you know that.
Yeah.
You're an oncologist. The other thing, I'll just say this, I know you didn't ask this question, but we don't know how to do these trials, right? Because we're coming from either the autoimmune section of the FDA or the kidney section of the FDA, whereas all these CAR T studies were done in the oncology and hematology section. So it turns out that they're actually looking at doing single-arm trial for CAR T cells in lupus because nobody knows how to make a placebo-controlled, randomized, blinded study, which is fascinating because I think that's what you all do sometimes in these malignancies, right? Single-arm trials.
Sure.
So it's quite a change for our field.
Very quickly, the
Yeah.
CAR NK are primary NK or NK92 cells?
No, they're primary
Primary.
NK, yes, yeah. And they're allogeneic, but they've been hypoimmune, made hypoimmune.
Thank you very much.
Other question? Qualche altra domanda? Qualche considerazione? Se no, thank you so much, Professor ROVIN, for your excellent presentation. E prima di concludere voglio dare i risultati della votazione. Tutti i soci preposti sono passati ovviamente, i votanti sono stati 73, quorum era 37, il maggior numero di voti l'ha ottenuto la dottoressa Daniela Rossi, 68 voti, poi Luisa Brussino 63, Armando Genazzani 62, Gianluca Isea e Giovanni Rolla 60 e Felice Borghi 59. Sono passati tutti e prima di salutarci e di invitarvi a un frugale rinfresco offerto dalla Società Bonifanti che da anni dà il panettone ai soci presenti, vi annuncio che la prossima riunione sarà a gennaio, 14 gennaio del 25 alle ore 21, una riunione del titolo Esercizio fisico come terapia delle malattie reumatiche, introdotti da Enrico Fusaro. Parleranno Simone Parisi e Luca Semperboni. Con questo abbiamo finito la serata, abbiamo finito l'anno. Vi auguro a tutti voi e alle vostre famiglie un migliore auguri di buone feste e ringraziandovi per l'attenzione e per il contributo che date tutti all'Accademia, vi auguro una buona serata e vi invito appunto ad un breve e fugace cocktail. Buona serata.